Hey, this is Cassandra Hughes, and I'll be presenting the treatment portion of the subset LGBTQIA+. So what I found here in a document by SAMHSA is that a lot of the approaches for the LGBT community are based on their treatment readiness and abstinent-based. And this was quite surprising due to recent developments in harm reduction and alternative approaches that cater to specific minority groups. However, on this next slide here, there was a breath of relief. The Fenway Institute, as called TFI, is an interdisciplinary center for research, training, education, and policy development, specifically with LGBTQIA+ people and those affected by HIV and AIDS. TFI is housed within Fenway Health Community Health Center, founded over 45 years ago, Boston-based, a nonprofit, federally qualified health center, and they've served over 30,000 patients in 3 different practice sites. What I found here was a specific curriculum used to integrate evidence-based practice and also clinical application and expertise. And this is a great resource for anyone who is interested. There were different webinars, publications, learning models, some toolkits, videos, handouts, and I have the link included here below. So this is what was found as far as what's offered in Kentucky. There's one location here where they offer the trainings and specific education for giving those quality care to the LGBTQIA+ populations. This mimics a lot of what was presented earlier by my group members. LGBTQIA+ people are disproportionate substance use disorders, and it's believed that it's downstream effect of minority stress. Substance use mediates the relationship between life stress and sexual risk among LGBT people. So what we have here is a framework that these external stigma-related stressors affect their psychological processes, thus becoming an internal stigma-related stressor, which results in behavioral health problems and later physical health problems. This was a specific intervention of 10 sessions for HIV prevention, but it also tailored to LGBT patients due to the minority stress and also the risk of substance use. We have life steps, sexual decision-making, cognitive behavioral therapy, cognitive processing, and then summary of all the modules. What was nice here is tailoring to the LGBTQIA+ patients, both with cognitive behavioral therapy and then also approaches due to minority stress. It was also found to be beneficial to integrate different theories, queer theory being theory that takes position of gender roles, gender identity, and sexual orientation as a construct and self-construct. And then also to go beyond binary gender categories of feminist and gender theory, and to integrate the importance of social construct and how that has an impact on one's identity. Additional topics to explore during treatment family, societal rejection, social supports, stigma, minority stress, harassment, and abuse. Person-centered language. An example might be Cassandra, who is bisexual, versus Cassandra is, or she's a bisexual, right? The person comes first. So what I have here is some ways to increase cultural competence and care. I think one of the concerns in treatment was if there aren't specific approaches for an individual, then what can be adjusted or tailored to accommodate. This was interesting and beneficial. So this showed different models from agencies and determined if they were pro LGBTQIA plus treatment or if they were against. And there's a scale here from least to greatest on a 6-measure scale. If provision of care for LGBTQIA plus proves lacking, there's some additional principles that can guide an agency towards better practice. Being flexible, person-centered, coordinated, integrated, comprehensive, consistent with cultural needs and expectations. Promotion of self-respect and personal dignity, promoting healthier behaviors, empowering persons, reducing barriers to service and those hard to reach populations, and work to create a treatment and recovery community. The difference in mental and physical health suggests that additional screening, training, outreach, and integration of healthcare services are warranted to meet the need. Given the disparities described here, it is essential to that providers offer services that are inclusive and that services are provided in a manner that is affirming and responsive of unique healthcare needs. So some of the suggestions were to assess for sexual orientation at intake, train staff and counselors, create an inclusive and affirming treatment environment, coordinate physical and mental health care. I liked some of the questions that differed for assessment would be where someone's comfort level was with their sexuality, how open they are about their sexuality, how their sexuality and their gender expression has been received by loved ones and support, all of those having an impact on treatment. So in searching for treatment and support in Kentucky, I went to the Google and found 18 listings, but none of which were specific to the LGBTQIA plus community. Just a variety of those had that they were inclusive, that they were a welcoming environment, but none that catered specifically to the subset. And I did notice a commonality among the majority was that they are trauma-informed care focused. I have some options here in metropolitan areas for specific peer services and 12-step meetings. Covington, Elizabethtown, Florence, Georgetown. And I believe that is all I have as far as my presentation. I'll hand it back over to my group members. Thanks.